folks, just calling back to the meeting, and we have about 5 minutes left. We've got some folks in our waiting room, and so excited. It's going to be a fantastic presentation. So please come back to, and I have started the recording, so that will be ready to go, and we'll have that all set up beforehand.
So do you want me to put up the first slide now or after
That would
the
be
first?
great. Yeah, I don't know what you like to do. Sometimes folks like to see everyone's faces before, launching into the presentation, but really it is up to you. I am here no matter what.
Larry, what do you think?
Let's put up the slide.
Okay. You see it?
Yep. Looks great.
Yep.
It's just not in presentation mode.
That's the only
I'll
thing.
turn it on to the presentation mode, Larry, when you are ready to start that.
Okay.
Would everyone like me to start letting folks in now to get settled, or would you like me to do it directly at noon, our time, Eastern time?
You can let them in.
Okay. I'll admit them now. Welcome, everyone. Thank you for joining us for this person-centered psychopharmacology and the promotion of self-management. We're so glad you're joining us. Please feel free to let us know where you're coming from, what your role is in the chat, and I will turn it over to Larry Davidson.
Thank you, Lee. Good morning or good afternoon, depending on where you are in the country. Welcome to the New England Mental Health Technology Transfer Center's webinar on person-centered psychopharmacology and the promotion of self-management. My name is Larry Davidson, and I am the director of the New England MHTTC, as well as a professor of psychiatry at Yale University. And I am joined today by Machiri Kechavan, a professor of psychiatry at Harvard University, who is both a member of the MHTTC senior faculty and a world-renowned expert in the understanding and treatment of serious mental illnesses. This webinar also marks the release of a new resource from the New England MHTTC, which is a guide to the principles and practices of person-centered psychopharmacology and the promotion of self-management for persons with serious mental illnesses and or substance use disorders. Today's presentation, no, Kesh, wait, go back. Go back. I haven't gotten there. Go back again. Okay, stay right there. Today's presentation will highlight the care of persons with serious mental illnesses, and a future webinar will highlight the care of persons with substance use disorders. Before we begin, I just need to go over some housekeeping issues. Now change the slide, please. As this slide suggests, participant microphones will be muted, and if you have questions during the event, please use the chat function. The session is being recorded and will be available in a couple of days on the MHTTC website, which is also where you will find the practice guidance I mentioned a moment ago that we are launching today. The New England MHTTC and all of its activities are funded by U.S. Federal Substance Abuse and Mental Health Services Administration. Next slide, please. But the opinions expressed today are the presenters only and do not reflect the official position of SAMHSA. And finally, the MHTTC network uses, next slide, affirming, respectful, and recovery-oriented language in all of its activities. That is language that is strength-based and hopeful, inclusive and accepting, healing-centered and trauma-responsive, inviting, person-first, non-judgmental, respectful, clear, understandable, and consistent with our actions, policies, and procedures. Next slide. So now, why focus on person-centered psychopharmacology and self-management? Well, it's been 20 years now since the Institute of Medicine called for practitioners to shift to, quote, care that is respectful of and responsive to individual patient preferences, needs, and values, and ensures that patient values guide all clinical decisions. Next slide. But 20 years later, it remains a challenge about how exactly to do this, especially in the care of persons with serious behavioral health conditions. At the same time, accumulating evidence has suggested that while some people with some serious mental illnesses may benefit from antipsychotic medications for extended periods, others may experience significant improvement when medications are used sparingly. Also, there is significant underprescribing of effective medications for opioid use disorders, with few people with substance use conditions being offered them. And as we see in the current tragic epidemic, many are dying. Next slide, please. In addition, a core component of person-centered care is shared decision-making, which is being advocated as an ethical imperative that both CMS and private payers are promoting, and which has been shown to both increase adherence and improve health outcomes. But how do you engage in shared decision-making with someone whose judgment may be impaired by having a mental health or substance use condition, or with people who are not aware of or may deny that they are in need of medication? What does shared decision-making look like for them? Next slide. Next slide. These are important questions because within the context of recovery-oriented practice, patient choice is rightly recognized more as a matter of fundamental human rights than a mere preference. In all but the most extreme cases, people retain their rights to make decisions for themselves, even within the context of an involuntary commitment or incarceration. We consider it not only an ethical imperative, but also a therapeutic intervention to protect and promote patient autonomy to whatever degree possible. And finally, having a sense of personal agency and confidence in one's own decisions and efforts are two of the fundamental building blocks needed for people to practice self-management and pursue recovery. So following, next slide, please. There is the practice guidance that I mentioned before that is now available on the New England MHTTC website. Following the webinar, we encourage you to download this new resource. Now I turn the microphone over to my esteemed colleague, Dr. Kechavan.
Thank you, Dr. Davidson. I appreciate the introduction on on person-centered care, which is central to 21st century medicine across the board. As I think about it, there are at least 3 goals that we all should be mindful of in our day-to-day practice of care, including prescribing. First of all, we need to develop a shared understanding of the illness with our patients, which is critically important for developing what I would call a positive therapeutic alliance that would help successful care. Secondly, it's important for the prescribers to understand why patients do and why some do not agree to take medications. So in other words, we need to understand prescribing from the perspective of our patients. And thirdly, we need to understand the approach to shared decision making, which I will go into some detail as to the principles of that. Now, let me begin with Therapeutic Alliance, the central cornerstone of medical practice and in psychiatric practice is the development of a therapeutic alliance. So what is a therapeutic alliance and what are the key components of a therapeutic alliance? First of all, the therapist and the patient need to have a set of goals that they share and agree upon. And secondly, the therapist and the patient have to agree on a plan to address those goals that have been agreed upon, a shared plan. And thirdly, there needs to be a bond or a trust between the patient and the therapist, which involves respect and acceptance. So these are the 3 key principles that have been identified going back to Borden in the 1970s, which he calls it as the 3 key pillars of building a therapeutic relationship. With that in mind, let's go a little bit into the relationship between psychopharmacology, which is what this talk is about, and its relationship to psychotherapy. A good prescriber always uses psychotherapy when prescribing, whether intentionally or not. Sometimes I'm a little uncomfortable with the word prescriber because it implies that prescribing is all that the person does. Absolutely not. A prescriber is a therapist. So prescribing goes with some element of psychotherapy. So the psychotherapy may just take the form of compassionate understanding of the sake of the state of the patient who is looking for helper outside him or herself. So in other words, when we see patients, we not only talk about the medicine and how they are, doing with the medicine, but also tell me a little bit about what else is going on in your life beside the illness. And that is good prescribing. And this is true for all prescribers, not just mental health clinicians. But remember that all prescribers are frontline clinicians themselves. And so Tom Guttheil and Heinz Kohut have described what is called a Pharmacotherapeutic Alliance. In therapy or in prescribing, the key tool par excellence is empathy, which allows the creation of a relationship between the patient and the prescriber that can offer some way of mitigating self-pathology. Pharmacotherapeutic Alliance is an active collaboration with the patient involving shared inquiry, which I'll talk about. shared goals and a mutual participation in both experiencing and observing the process of using medication. Let me illustrate this by the example of a young lady that I took care of many years ago. This was a 32-year-old college lecturer who was treated successfully for 2 psychotic episodes. Her symptoms were paranoia and auditory hallucinations. She had been symptom-free for over 3 years. So I had been able to reduce her risperidone gradually to 2 milligrams per day. Given that she had had 2 episodes of psychosis already, I thought that she needs to continue the medications to prevent a relapse. And that is what I had recommended to her. However, she got a better job in another state, and she wanted to discontinue her medication because she had been symptom-free and was stable for a good length of time. So even though I suggested that she needs to see somebody in the other state that she was going to go to, she declined, and she said, doc, I think I'm fine now. I can manage without medications. Even though I recommended that she continued a small maintenance dose at least and follow up with a clinician in her new location. She was reluctant to do so, but she, however, agreed to stay in touch with me. So this is the kind of situation we face quite often. And then I lost contact with her. And this is what happened. 2 years later, I received a call from her who was in an airport. And she reported that she had suddenly begun hearing voices coming from a nearby air conditioner. She wanted to get back on risperidone as soon as possible. So I gave her a prescription. She promptly responded to treatment. So there are some lessons to learn from this kind of case. And let me ask you the following question. Why do you think Ms. T contact me at this point in time? There are a number of possible reasons. Is it because over the course of time, she had developed some insight into her illness? Number 2, risperidone had helped her in the past, and so she knew it might help again. Number 3, she trusted this clinician and had a shared goal with this plan, about this plan. Number 4, all 3 of the above. I think Lee is going to send the survey, and please answer with your question, with your response. Looks like we almost have 100% response. Lee, are you going to be sharing the results?
There's the results for us to look at.
Sorry?
I have shared the results on screen now for folks.
Okay, great. Yeah, thanks. I'll stop sharing. And you all saw that the answer is all 3 of the above. So, of course, there's no question that she would have developed a little bit of insight. And there's no question that she knew that risperidone had helped her in the past. But then, why would she have even come back to me if she did not trust me? So there was an alliance there, even though she had kind of disagreed with my recommendation and gone away. what kept her going and what got her back, despite in the middle of her psychosis, to call me, was because she had that alliance. So it's critically important, even when we no longer see the patient, that trust is likely to help. And the connection, the emotional bond that exists between the patient and the clinician. I don't use the word the prescriber because I think it's too limiting. The clinician is what I would say. It's very important. So moving on, a positive therapeutic alliance can have lasting benefits, and not just for the period that you're seeing the patient, but even beyond. So let's think about another case, which will give us an example of how to address someone who is not even agreeing to treatment. What we saw so far is someone who agreed and was going away from the therapeutic encounter. So Lucy is a young lady who presented with gradual social withdrawal, talking to herself, and believes that she is the Messiah destined to eliminate poverty from the world. She had dropped out of her university. She was an electrical engineering major in her sophomore year because she had failing grades and disinterest in attending classes. She had disagreed with the diagnosis of schizophrenia by 2 other physicians and had only grudgingly agreed to see this prescriber, which happened to be me. And so the reason she had not agreed with the 2 other psychiatrists is because they both said you have schizophrenia and it is a chemical imbalance, and you will need medications to fix that chemical imbalance, and you may even need the medicine for life. So she completely disagreed with those. So when I saw her for the first time, she denied all psychotic symptoms, but admitted to being unhappy about dropping out of college. So there was a problem. She agreed with me that she didn't really need to drop out of college, but she did. And I asked her, why did you drop out of college? She said, even though she liked the topic of her studies, she could not pay attention in classes because her mind was being cluttered because of a chatter inside her head. She did not agree she has schizophrenia, but she agreed that she had a cluttered mind, which is what was making it difficult to pay attention in classes, and this is why she dropped out of school. She was willing for help, but did not believe she needed medications. She did not believe that she had a chemical imbalance in her brain. So how does one approach this kind of a situation? And let me ask this question here. What may be the main reason why Lucy is, by the way, Lucy is not her real name, and I'm calling her Lucy for the purpose of this presentation. Why is she refusing medications? A, her refusal to acknowledge need for help. B, her inability to make a competent decision because of severe illness. And C, because the previous prescribers had not given her a model of her illness that she agreed with. So Lee, if you could, put out the survey. Thank you. Okay, it looks like the majority of you answered C. That is, the previous clinicians had not given her a model of her illness that she was in agreement with. And it's a very important point. When encountering a patient who has an illness of which the diagnosis, she's not agreeing with you, it is up to the clinicians to develop a way in which to find a point of agreement and find a model of illness that would be acceptable to the patient. So how might one go about doing that? So, as I said, Therapeutic Alliance develops best in the context of a shared understanding of the illness and shared decision making. Xavier Amador, a psychologist who has written this very, very good book called I'm Not Sick, I Don't Need Meds. If you haven't read that, you should take a look at that book. He came up with the principle of what he called the LEAP principle, and that is listen to your patients, empathize, find a point of agreement, and develop a partnership. So I'll expand on this by telling you what approach I took in this particular case. So when further inquired, Lucy said she was studying in college about radio and transistors. She was an electrical engineering student. So when I asked her about how an electrical engineer would explain why a radio is unable to tune into the right station, I suggested to her that, maybe the signal is low. And why she gets a lot of static. She herself pointed out that the voices inside her head might be like the static. And the fact that she was not concentrating and the difficulties with attention may be because of a low signal. So basically, she herself came to the understanding that there might be a problem that might be reflected in a low signal to noise ratio. And then I pointed to her, is it possible that if your brain were like a radio out of tune, could that explain her inability to concentrate? And the chatter inside her head might be the symptoms that she's experiencing. So she was willing to consider that possibility at this point. And then this led me to explain how dopamine might govern this tuning function in the brain. And if this is unbalanced, like too high an activity of lower brain regions, the dopamine circuits in the lower brain, the limbic brain, and too limited the functioning of the higher brain dopamine, namely the cerebral cortex, that could lead to kind of this imbalance with a low signal and a high noise. And a medicine like aripiprazole, which could correct that imbalance, could help, correct that dysfunction. So that led Lucy to agree a small dose for a while. And so the reason I bring this as an example is that in every patient, we may need to figure out a way in which we can explain how the medicines might help. In this case, she was a very intelligent woman. She had the right kind of understanding to even think of a metaphor for the brain, but that may not work for everybody. In some people, it may be simply identifying a symptom. Maybe, you're not sleeping well enough, and perhaps getting better sleep and a medicine that can help you think more clearly is the way to go. And let's not give it any particular diagnosis. Let's go with just the difficulties you're having. Find a point of agreement which she will agree with and what you will agree with, and then work with that agreement. Diagnosis sometimes doesn't even help as an initial way of introducing the topic of medication treatment. I'll come back to that in a moment. So, in the rest of medicine, there is a lot written about how do we even share diagnosis as a step to developing a positive therapeutic alliance. But in psychiatry, it is even more complicated because there are often the issues of stigma and the lack of insight, which makes it difficult for us to share the diagnosis with our patients. It's a little bit different when it comes to sharing a diagnosis of a medical disease, whether it's cancer, whether it's an arthritis, or whether it's a heart disease and so on. But in psychiatry, one needs to follow certain key principles in which I came up with this acronym called INSPIRES. In every situation, every individual, we need to individualize our approach to sharing the diagnosis. Not everybody approaches the same way. Each person's life situation is different. And to the extent possible, if we can normalize our descriptions, for example, you're talking about, let's say, experience of paranoia. Rather than jumping into a technical term of paranoia, you could say, sometimes people have difficulties trusting others, mistrustfulness. So use language that is much more normalizing. Also, identify the setting in which you share the diagnosis. Sometimes it helps, when you're dealing with a first episode patient with psychosis or a first episode bipolar disorder, and you need to talk about the diagnosis. And when the families are still very involved, it's important to involve the family, involve other team members as well, so that you get everybody on the same page. And also get the perspective of the patient. These days, the patients know a lot more, because they have at their fingertips everything. They may have gone to Google, Wikipedia, and have read about all sorts of things, sometimes accurate and sometimes inaccurate. So find out what they know already and what they don't know, and that helps you define an approach, an effective approach in sharing the diagnosis. And of course, our information, whatever we provide, needs to be accurate and complete. We need to have all possible information in our fingertips before we talk about diagnosis. And often people don't process everything, especially when they are acutely symptomatic. Repetition may be necessary, a lot of reassurance, and allowing our opportunity to ask questions. And of course, to empathize, put yourself in the patient's shoes and provide some power, some empowerment for patients to read and ask questions and come up with alternative explanations and so forth. And finally, no diagnosis should be really shared without offering a solution. So give them a plan, give them the next steps. And, fortunately in psychiatry, unlike some areas of the rest of medicine, there's always some solution. We very rarely, if ever, deal with immediately life or death kind of situations. There's always a plan, and it's important to share that. Now, the second major point that I want to bring up in this talk is for the clinician to understand why patients do and why they sometimes do not agree to take medications. So putting yourself in the patient and getting the patient's perspective is critically important. And this is essential for developing a therapeutic alliance. We have to become humble and know that even though we may know more, about medications and their doses and what they do to the body and so forth. The patients are the experts in how the medicines make them feel, how the illness makes them feel, and what life situation they are in. So it is the joint venture between the patient and the clinicians to find their way through the appropriate treatment, whether or not to use a medicine, the appropriate drug, the dose, and the side effects. And in psychiatry, even more so than the rest of medicine, adherence is not to be not to be taken for granted. This slide from the field of cardiology, there is a loss of a significant number of people who don't even fill their prescriptions. And even if they fill their prescription, a good number may not even start the medicine. And even if they start the medicine, a good number don't even finish the treatment. And a sobering statistic, which I don't have in this slide, is that the KT study, which was a large multi-site study of antipsychotics, showed that 74% of people who were started an antipsychotic were not taking the medicine at the end of 18 months. So the majority of people drop out of treatment, and there are multiple reasons for that. And you can broadly classify non-adherence, or there is no consensus as to what is the best term for adherence. Some people, the older name used to be compliance, which is not at all good, because you don't comply. And then even the term adherence is not that great, because that again gives a kind of an unequal implication between the clinician and the patient. So there's no good name for it. Treatment satisfaction, treatment alliance, treatment acceptance. So one could consider any of those. And there are two kinds of those. There is unintentional non-adherence or non-acceptance, and intentional non-adherence or non-acceptance. And when it comes to medication, of course, I'm not going to go into a lot of the details here, the reasons for non-adherence or non-acceptance, the reasons that are based in the pharmacology itself, in terms of simplifying the complex medications, the efficacy, the side effects, and the cost, and so on. That's one part of it, and it is up to the clinicians to make the medicines easy to use and have minimal side effects, and choose the most effective medicine and work with the cost issues and so on. And then there are unintentional issues, which include forgetfulness, misunderstood directions, medical comorbidities, health literacies, and so forth. Again, this is up to the clinician to work with the patient to address these issues. But the most important issues, are equally important issues, are the intentional non-acceptance or non-adherence, which is what I'm going to spend more time on. And that is the perception of the treatment and illness, the denial and anger about the disease itself, the inappropriate expectations, dissatisfaction with healthcare providers, and cultural and religious issues, and so on. So there are three basic mistaken assumptions that clinicians often make, and we need to consider these three assumptions. The first assumption is that modern medications correct an underlying chemical imbalance of illness. But the problem with that assumption is that the patients may not exactly see it that way. Medications have different meanings for different individuals depending on their psychological states. Not everyone would always agree about taking medications. Some people don't want medication. Some families don't want medications. And patients' beliefs, on the other hand, are derived from parental beliefs, family beliefs, Sometimes they feel medications are good, helpful, safe, and modern technology, or they may feel that they're toxic and dangerous, a sign of weakness. They may also be listening into advertising and misinformation, internet, friends, religious concerns, prior medication experience. All of them play into patients' beliefs about medications. So the astute prescriber will attempt to understand these factors before prescribing. And why some patients, agree to take medications is because they are seeking relief from their illness, and the pain and the suffering. And other reasons might be because they are looking for validation that they're sick, or because they use medication to solve non-illness problems, or because they may use medication as an entry level to a non-prescription treatment. So like, doc, can I just learn something by you? Of course, their main pretext of coming to see you is to get a refill. But then they really want to talk to you about something else. And then, typically I see this quite often, at the end of a 15-minute med check, which is really a terrible thing that has happened to psychiatry. And when we have talked about the basic things about how they're doing, and then they say, just as the time begins to, end, doc, as long as I'm here, can I say bring up something else? And that may be the most important thing that they're bringing, but that happens. So we have to provide enough room for that option. The second basic assumption is that psychiatric medications are necessary and sufficient. They absolutely are not. The point to keep in mind is that not all medications, not all psychiatric illnesses need medication treatment. And when medications or psychotherapy are indicated for a patient's treatment, the outcome is better when both forms of treatment are used together. And medication may be a useful beginning to treatment that can evolve into a psychotherapeutic relationship over the course of time. And not all problems require medications. Over-medicalization is a problem that we should, be mindful of. Not all unhappiness is depression. Not all enthusiasm is mania. Not all worry is anxiety. Not all disorganization is dementia or ADHD. And not all bizarre thoughts and beliefs are psychosis. Not all habits are OCD. So, it is up to the clinician to make that distinction where a normative dysfunction borders on into a psychiatric disorder. The third assumption is that all medications are safe and effective, which is not the case. No medicines are fully effective. No medicines are fully safe. And medicines are never a permanent solution. They can be a start for something, that is a good solution from a psychotherapeutic side. And as I said before, there are some positive psychological meanings for psychiatric medications. For the patient, it may be a way of having you when you're not here. It's a way of maintaining a therapeutic relationship. And often the medicine is simply kept as a crutch. To give you an example, I have had some patients who have, say, panic attacks. And I tell them, look, this medicine, let's say Ativan, the lorazepam, can help you avert an attack if you get a sense that you might be going into a panic attack. But I tell them that you don't have to take it. Just keep it in your purse or wallet and keep it handy. So this is a kind of a sense of safety for you. You can manage in most situations when you feel like you might be coming down with a panic attack to take a deep breath, take a few deep breaths, get off of whatever you're doing and, go for a walk or something like that. The panic attack will go away. And many patients that I use this approach, they end up not having to take the medicine at all, but they have just a couple of tablets of Ativan in their purse, which they have never used. So it can be used as a sense of safety, but not necessarily as a regular thing. So medicines may also provide a soothing function in addition to its pharmacological properties sometimes. And prescribing may mean that the patient's suffering is taken seriously as opposed to being simply dismissed as a complainer or a weak or manipulator. And when the patient feels understood to the degree that medication they prescribed, that can be helpful for the Therapeutic Alliance. When the patient feels dismissed by being handed a prescription without the prescriber's understanding of the apparent indifference, that is not good for Therapeutic Alliance. So one should never have a visit with just the prescription. It should always be combined with some psychotherapeutic element. There are negative psychological meanings for medications as well. Sometimes patients might feel that taking medicines means losing control, and I might become dependent on it. Or they might, have a lack of trust on authority figures, which might include the clinician, the drug companies, or the pharmacies, or they may not trust the medicines, fear of negative consequences and side effects. All of these one can work with, but we need to know what the patient's perspective is. Medicines, some patients might also feel that the medicines prove that I am inadequate. Taking medicines is a sign of weakness. My last point in this talk, and I'll try to see how I'm doing with time. So, is about therapeutic decision making or shared decision making. It's an important concept that Dr. Davidson mentioned at the beginning as a central piece of personalized, person-centered medicine. So what is shared decision making? The fundamental principle is that no one makes a decision in a one-sided manner. In this cartoon, you want to speak to the head of the household, there is no head of the household. My parents are into shared decision making. Likewise, shared decision making is a partnership between the clinician who has the knowledge and the skill set for making an informed medical choice, whereas the patient has the knowledge of the subjective experience of the illness and the medication effects and brings to the table a personal perspective. So a shared decision making is a partnership that combines these two things. Just to take that one step further, the clinician's decisions, which are based on a knowledge base, which is informed medical decision making, is paternalistic. Whereas when combined with this informed medical decision making, with the values and the preferences that the patient brings to the table, then that becomes shared decision making. So it's an interactive process. This interactive process, shared decision making, is the center of three things. One is the clinical evidence from the literature and the expertise that the doctor brings. Number two, the biological and the psychological and the social context in which the treatment is happening. And thirdly, the patient's and the family's goals and preferences. When all three of those are combined, that is, in other words, what the doctor knows and what the patient's illness context is, and the history of the illness, and the prior response to treatment, and the various factors that determine potential therapeutic response. And finally, and equally importantly, the goals of the patient and his or her preferences. And that is the key principle. All three converge to create this shared decision-making concept. There's increasing evidence. Bob Drake wrote a very nice review of this some years ago. Increased patient satisfaction, increased better adherence to treatment plans, greater treatment engagement, and greater quality of decision making all stem from shared decision making. And there are some essential steps for shared decision making. First of all, the clinician needs to seek the patient's participation. And secondly, the clinician needs to help the patient to explore and compare treatment options, provide them with choices, and then assess the patient's preferences among those choices, which may be consistent with the patient's own value system and the life situation. And then fourthly, reach a decision with the patient and then evaluate the patient's decision and potential outcomes. So those are this is a combined together called the shared approach. And help the patient to ask 3 key questions. First of all, the patient should be encouraged to ask, what are my options? What are the possible benefits and risks with these options? How can we make a decision together that is right for me? So those are the 3 questions that the patient should be encouraged to ask. So let's look at this one case. Again, a patient of mine from some years ago who illustrates the point of shared decision making. So this young lady, a 38-year-old single woman, treated in an outpatient clinic for schizophrenia. She has had recurrent relapses and hospitalizations despite treatment with 3 atypical antipsychotic drugs: risperidone, quetiapine, and aripiprazole. However, over the last year, she responded well to clozapine, 300 milligrams per day. Even though she was troubled by the excessive sedation, which was making it difficult for her to get up in time to get the kids ready to go to school. Sometimes kids were missing school because of her sedation. So now this lady, she wants to discontinue clozapine as she's afraid she may lose custody of her 3 children, because once even the police were called when the kids were crying inside, and she wasn't up from bed by noon, and the neighbors got concerned. So she got really concerned about whether she would lose custody of her children. So this is what happened. Let me ask you, what is the best option for the prescribing clinician? A, would you strongly recommend continuing clozapine since she had not responded well to 2 other antipsychotics? B, would you discontinue clozapine and start her back on her previous medications? And 3, would you discuss with Ms. M the pros and cons of discontinuing clozapine and present her with the options of continuing clozapine plus an alerting medicine like modafinil, or even reducing the dose of clozapine and giving it a trial, or a trial of an alternative antipsychotic with less sedating effects like the racidone? Looks like I already see about 93% of you saying option C. So option C is an example, which I took in this case, of giving her the choices to the patient. Look, these are the options. Would you be willing to try clozapine with modafinil, and then if it doesn't work, maybe perhaps reducing clozapine dose a little bit? Or would you go with something with which you had 3 previous relapses? She chose to give me an option of continuing clozapine with an alerting medicine. And that worked out okay. So that is an example of shared decision making. Now, it may not always be possible. So shared decision making works in the majority of time, but sometimes it may not work. So let's think through these issues. So there are three key questions to consider. First of all, is there more than one reasonable option? So in the case that I described, there were more than one reasonable option. But if it is not, we just have no other option than, if she refuses, get her consent to refuse, and then try to make a compassionate persuasion for her to continue. And, that those are the only options left. And then there are situations where the patient is unable to competently consent, or there might be no time to engage in a discussion. So there's no time to engage in a discussion. Patient, let's say, presents to you with a catatonic stupor, and there is no way the patient is able to give you an informed consent. Or it's an emergency situation where the patient is acutely agitated and symptomatic, and any attempt to engage the patient has not worked. In such situations, the physician may have to make a decision, perhaps with a second opinion, and perhaps a involuntary administration, which hopefully should be very rare. But again, in most patients, as I said, there is more than one reasonable option. The patient is more often than not willing and able to participate in the decision, and more often than not, there is enough time to engage in the patient in a discussion. So in summary, my first point is that a key first step in effective treatment is therapeutic alliance. A shared understanding of the illness is critically important for developing a positive therapeutic alliance. My second point is that it is important for the clinician to understand why the patients would want to take or not accept medications. And that is important in helping to develop a treatment plan. Thirdly, whenever possible, one should engage in shared decision making, which can enhance therapeutic alliance and improve outcomes. I think that's my last slide, and I want to thank you, and I'll stop sharing my slides, and maybe there is an opportunity for a few questions.
Thank you, both of you, for the presentation. It was wonderful, outstanding. And if you have any questions, please, you can just write in the chat and we'll be answering all your questions. So the first question is, do you recommend medication for students?
Well, depending on the nature of the illness, students may need medications. But then again, in the spirit of the principles that I talked about, the clinician needs to develop a shared understanding with the student about the benefits versus the risks of the medicine, number one. And number two, it's important to give choices as to what medicines might support versus might interfere with the student's goals. So if the student, for example, feels that he has to really be able to stay alert and concentrate on his studies and be prepared for the upcoming exams or things like that. You would want to give the options of a medicine that is less sedating and work with the minimum dose that is needed to help address the symptoms, but at the same time help the patient move forward with his or her goals. And also, it is not just medications, and often the students are coming to you because not only are they experiencing symptoms, but the symptoms may be related to the academic demands that they are experiencing. And so it may be important to engage in psychotherapy that will help develop coping skills for them and even make the appropriate adjustments as needed to the academic load that the patient is experiencing.
Thank you. Denise asks, what about the role of the family in shared decision-making?
That's an excellent question. Quite often there is no family that is involved. And in that case, the option would only be working with the patient. But quite often there are family members. And it's important to involve the family not only in the shared decision-making for treatment, but also in sharing the diagnosis, as we talked about at the beginning. And again, it has to be done using the principles that I outlined. We have to involve the family, being mindful of the patient's perspectives and the setting in which we share such information. Sometimes patients may be totally against sharing with the family, so we'll have to work with that. But thankfully, most situations, the patient is accepting of the family members being involved, or other caregivers. And whenever that is the case, to have a family meeting and work with them to answer their questions and take their perspective. Because often, even though the patient may agree, if the family members are against medications, you're not going to see a good outcome, because they may encourage the patient to go off of the medication, and then that could be counterproductive. So getting a buy-in with the family members is critically important from the get-go.
Well, thank you, Dr. Keshavan, for an excellent presentation. Thank you all for attending today's webinar, and look out for future episodes on a similar related topic.
Thank you all.
Thank you. Have a good day.